Good afternoon, everyone. I'm going to talk about management of urinary tract infection. I do have a disclosure. I have received grant funding from Merck for one of my research projects. However, I do not see any direct conflict with this talk. These are my learning objectives, and I fully intend to cover those in my talk today. But before I jump on to talking about management of urinary tract infection, just want to clarify some basic terminology or definitions that we are going to be using. So urinary tract infections, it refers to the infection anywhere in the GU tract. But when we talk about cystitis, we're talking about symptoms or infection confined to the bladder, usually manifest as dysuria, frequency, gross hematuria, suprapubic tenderness, or new or worsening urinary incontinence or urgency. Now, when we talk about pyelonephritis, it's a less common infection, but it's more severe, and it involves renal parenchyma. And when it manifests usually as fever, chills, back pain, nausea, vomiting, and localizing bladder symptoms may or may not be present, usually present, but can be absent also. Catheter-associated urinary tract infection refers to UTIs in patients who have catheters or whose catheters have been removed in the last couple of days. And then asymptomatic bacteriuria is the presence of bacteria in the urine without any signs and symptoms of urinary tract infection. So you have bacteria, but no signs and symptoms. I'm going to stick to the asymptomatic bacteriuria for the couple of minutes. I want to talk first about the impact of treating asymptomatic bacteriuria. What happens if we treat asymptomatic bacteriuria? So this is a study that was done a long time ago, but was a 9-year study. It was a controlled clinical trial, involved elderly ambulatory women without any indwelling catheter. They did urine cultures every 6 months, regardless whether sign or symptoms or not. The control group did not receive any antibiotics. The treatment group got antibiotics if the cultures were positive, even though they didn't have symptoms. The cure rate, so once they did that, the people who got antibiotic, the patients who got antibiotic, did actually cure the asymptomatic bacteriuria. In these patients who were not catheterized, they did cure the bacteriuria. 83% cure rate, 15% only in the control group that were not getting treatment. However, the bottom line was that there was no statistically significant difference in the mortality between the two groups. So if you got the treatment, your outcome is the same. You cleared the bacteriuria, but long-term mortality didn't change. You didn't get the antibiotic, your mortality is still the same as the ones who got the antibiotic. So it did not have any impact on the survival. However, on the other hand, asymptomatic bacteria treatment promotes antimicrobial resistance. So in this study was also a randomized controlled trial, 35 patients with long-term indwelling catheters this time, 18 in the control group, 17 in the treatment group. They obtained urine cultures every week regardless. Whenever bacteriuria was detected, it was treated with 10 days of cephalexin in the treatment group. In the control group, they didn't treat. And if you see, the mean bacterial strains per patient in both groups was the same. So these patients who had catheter, they didn't even get better with the antibiotic treatment. However, if you see the resistance rate for cephalexin in the treatment group, the sensitivity is low, while in the control group, the sensitivity remains high for cephalexin. So that tells us that we didn't get any benefit from treating asymptomatic bacteriuria, but right away we dropped the sensitivity for the cephalexin that we were giving to those patients. So you're not going to any survival benefit, but you're getting antimicrobial resistance. So why do we treat? We shouldn't be treating asymptomatic bacteriuria. Case closed. So IDSA just this year came out with an updated Asymptomatic Bacteriuria Management Guideline, which says it recommends against screening for and treating. So recommend against looking for and treating asymptomatic bacteriuria in most clinical scenarios. But there are clinical scenarios, like Dr. Cavalieri mentioned, where you should consider screening for and treating asymptomatic bacteriuria. Number one, pregnant women. You should screen for that, and if there is bacteria present, even though they don't have any symptoms, you should treat them with 4 to 7 days of antimicrobial treatment. The second patient population who you should screen for, and applicable for many long-term care patients, patients who are undergoing endoscopic urologic procedure that are associated with mucosal trauma. So any procedure that you are about to do urological, where you are going to expect bleeding, mucosal trauma, you should go ahead, do a urine culture prior to the procedure and do antibiotic treatment based on the pathogen that you identified on the culture before the procedure is done. However, how long you are going to treat that patient? 3 days, 5 days, 7 days, 10 days? The guideline says you need to give them 1 dose of antibiotic 30 to 60 minutes before the procedure. That's all you need to treat that patient for. So used to be in the past, we have seen people, oh, they are about to go for a urological procedure, give 10 days of antibiotic. Not the case. That was, I don't even think that was ever recommended 10 days, but you don't need any long duration of treatment for that. 1, maximum 2 doses, that's all. Now, when we talk about diagnostic testing for UTI, we need to remember that Dr. Cavalieri mentioned that there are limitations to diagnostic testing. We cannot diagnose UTI based on diagnostic test. We can use the test to make some management decision, but we cannot diagnose UTI based on this test. Why I'm saying that? If you see, there were 40 patients in this study that had UTI, and all of them, and this is the nursing home population, so let me clear it up. Nursing home population, 40 patients with UTI, when they were checked for the UA, nitrite and LE, either of them were positive, at least, let me rephrase. 40 patients who had UTI, they have either nitrite or LE, all of them. However, 49 patients who didn't have UTI, they also have either nitrite or LE. So the problem is that, what's the benefit then? People who have UTI have positive nitrite, positive LE. The people who don't have UTI have a positive nitrite, positive LE. It's not going to tell us anything. Okay? Same problem with the urine culture. So these are 243 urine specimens taken from 76 long-term care facility resident. Just asymptomatic, go in and start taking urine culture of everybody. Okay? Over 90% of them had bacteriuria. About 60%, over 60% of them had significant bacteriuria, more than 100,000 colonies, while they're not having any symptoms. You just went in and started taking cultures. They are positive. So what benefit does it get for us to identify whether somebody has UTI or not? When this patient population, at least the elderly patient population, we're not going to be able to make a diagnosis based on the UTI, or based on the urine culture or UA. So how are we going to make the diagnosis? We're going to make the diagnosis based on clinical symptoms. Now we're going to use the UA urine culture to make which antibiotic to use and all those kind of things once we have diagnosed UTI, but we're not going to diagnose it based on this. So what clinical symptoms we are going to use to make a diagnosis? Not confusion, not falls, not pungent urine, not smelly urine, not discolored urine. All of those things in this study, when they looked at people who did not have UTI and elderly patients who have UTI, and these were hospitalized patients who had UTI diagnosis and did not have UTI diagnosis, and they look for all of these symptoms, and they find out that there were no difference in the groups. basically. So people who have UTI had these symptoms. People who did not have UTI have these symptoms. You're not going to be able to diagnose UTI based on these symptoms. So if somebody has fallen, doesn't mean they have UTI. No, does not. The symptoms that they found were associated with UTI were dysuria, frequency, retention, suprapubic pain, flank pain, rigors. Those were the symptoms that were able to differentiate between UTI versus non-UTI cases. And that's what we should go by. Now, because it is so difficult in kind of making these decisions of when to start antibiotics, when to diagnose UTI, there have been guidelines specifically for these purposes on when to start antibiotics published in the last 10, 15 years. I have listed 4 or 5 of them here that you can use in your practice. I'm not going to go in details in any one of those except one, the very last one, but you can always get it through the internet. They are all probably free downloadable documents. So I'm going to talk about this 2018 guideline that came out just last year. And this is a guideline to diagnose uncomplicated cystitis in nursing home residents. What the guidelines author said is that when you are approaching a patient to diagnose UTI or diagnose uncomplicated cystitis, the first thing you need to figure out in the nursing home residents, the first thing you need to figure out is that whether they have any warning signs and symptoms or not. So what are the warning signs and symptoms? Fever, flank pain, rigors, prostate pain, urinary catheter, hypotension, increased WBC. If you find 2 of these in your patient, then that is not an uncomplicated cystitis. That's probably complicated UTI or pyelonephritis or something else related to that. So that's a different approach, maybe more aggressive approach. However, the rest of the patient who do not have 2 of these symptoms, you should look for dysuria. If there is dysuria present, then you find out whether they have gross hematuria, suprapubic pain, or urinary frequency urgency or not. If they have at least one of them in addition to dysuria, then you can diagnose cystitis. Okay, they give you another out. If you have hematuria or suprapubic pain combination, then you can diagnose cystitis. The rest of the symptoms, case closed. They're saying it's unlikely cystitis. So if somebody is having urinary frequency or urgency, based on this guideline, they're saying don't treat as cystitis. So what do? They say do active monitoring and evaluate for other causes that could have caused that. What is active monitoring that they want us to do? The active monitoring is a set of interventions. Basically, in very simple words, is saying observe the patient very closely, monitor their vital signs. Definitely they don't have any warning signs. Monitor their vital signs, do assessment for their fluid intake, encourage fluid intake, hydrate them, and then have a criteria to alert the physician if the patient is not getting any better or worsening. So in that scenario, if you have that protocol in place, if you're a nursing home, in your facility, if you have that kind of protocol in place, you don't need to start antibiotics. You can delay 24 to 48 hours because the diagnosis is not certain yet. There are many other reasons for having urgency frequency. So most patients with hydration will get better and the symptoms will go away. So that's not UTI. Now, when the nursing homes adopted this active monitoring protocol along with an assessment and communication tool, they saw a decrease in inappropriate asymptomatic bacteriuria antibiotic prescribing. So what is this assessment tool? We call it UTI SBAR. It is basically a checklist of different symptoms. So if you have catheter, if you don't have catheter, These are different set of symptoms that you have to look for. So when the nurse are evaluating the patient, they will go in, they will use the checklist, look for all these signs and symptoms, record that, and this checklist will tell them whether the resident is meeting the criteria for UTI or not meeting the criteria for UTI. So the next step they're going to do, they're going to call the physician and say, I saw that Mr. So-and-so was not acting right, was looking confused. I went in suspecting UTI. I did this form, S-bar form filled up. And based on this form, I didn't see any symptoms that is specifically for UTI. So the criteria for UTI is not being met. But based on our protocol, we need to place this patient on active monitoring. Are you okay with me placing this patient on active monitoring? The physician is most likely going to say yes. As long as there is a protocol for observation, hydration, I'm fine with that. And the patient is not having any warning signs, vitals are stable, we're fine with that. And most of the time, you will not then need anything. The patient will get better in the next 24, 48 hours. If they don't get better, and you do not find any other reason for their confusion, and they're still confused, then yes, you may then, in that case, try antibiotic treatment, and that's perfectly fine. Even though, it's possible that they may still not have UTI. This is the form the AHRQ has developed on the left. This is a 2-page UTI S-bar form. Some facilities didn't like that. They wanted a 1-page form so they can fax to the provider. So we developed a 1-page form for that. It's available on our website. You can get it from there. I will highly recommend all long-term care facilities to implement that S-bar form. It really has shown to be effective. Diagnosis of UTI in a healthy premenopausal non-pregnant woman is a little different, not completely different. You still have to diagnose UTI based on the signs and symptoms. So the signs and symptoms that we're talking about are dysuria, frequency, urgency, suprapubic, hematuria for cystitis, the same things for pyelonephritis. The difference is that you may not need to do a UA urine culture. You actually do not need to do a UA urine culture. In this patient population, if they have classical signs and symptoms, you can go ahead and treat them for UTI without even worrying about sending a UA and urine culture. Now, keep in mind that if they have sudden onset of symptoms or severe symptoms localizing to bladder, but absence of vaginal irritation and discharge, then they are more likely to have cystitis. If they have discharge, vaginal discharge, irritation, then maybe you can think of something else like yeast infection or something to that effect. But if not, then it is very suggestive of cystitis. Probability of cystitis is greater than 90% in those women who have dysuria and frequency without vaginal discharge or irritation. Now, UA and urine culture, as I said, is not needed for suspected cystitis, but it is needed for pyelonephritis. So if you're thinking pyelonephritis, then you should do a UA and urine culture. Cystitis, you can skip it. Okay, so I'm going to shift gear now. So we diagnose UTI, we know that there are clinical symptoms. How are we going to approach the treatment? So the points that we need to consider when we are deciding treatment option is what are the type of UTI syndrome we are treating. Cystitis treatment is different than pyelonephritis. Any previous culture that was done in the last 6 months to 2 years, try to find that out if it was done and use it, because it will help you guide your antibiotic treatment. If you don't have previous culture from the same patient, then you have to look at the antibiogram in deciding what antibiotic to start. And then other things to consider is renal hepatic function, drug-drug interactions, and other comorbidities when you are making your decisions on antibiotic. The reason I mentioned to look for previous urine culture is because the studies have shown that if you are using an antibiotic that covers whatever the bacteria was growing last time, in the last 2 months or in the last 6 months to 2 year time period, you are going to have better chance of covering the bacteria that is going to grow this time. But if you don't cover the bacteria that grew last time, this time around your chances of covering the bacteria is going to be much less. So that's why we need to find those old cultures if the patient have one. Now in terms of the treatment duration, how long you're going to treat them. So it depends on what antibiotic you are using. So and what syndrome you are treating. For uncomplicated cystitis, the first line agents are nitrofurantoin, trimethoprim sulfamethoxazole, and fosfomycin. Now fosfomycin we reserve for resistant organism. So the nitrofurantoin and trimethoprim sulfa are the more first line option in my opinion. So if you're using nitrofurantoin, 5 days of therapy is enough. If you're using trimethoprim sulfa, 3 days of therapy is enough if we are treating uncomplicated cystitis. Nursing home, outpatient, inpatient, same thing. Fluoroquinolones, please don't use that. But if you have to use that, if there is no other option, use it for 3 days and that should be enough. 3 to 7 days for beta-lactam antibiotic. This, by the way, this chart is on our website and it has also, beside UTI, some other infections also listed. So I just cut off the part for the UTI treatment. Pyelonephritis treatment is longer. It's 14 days with trimethoprim sulfa, 10 to 14 days if you're using a beta-lactam antibiotic, and 7 days if you are using a fluoroquinolones. If you are treating a catheter-associated urinary infection, it's usually 7 days. And all of these are based on guidelines. Guidelines are listed there, so you can always review the guideline. 7 days for CORTI. Or if you are treating cystitis in presence of complicating factors, so not the uncomplicated cystitis, but cystitis in presence of complicating factor, then 7 days again will be enough. However, if you have a delayed response to antibiotic, then you can go ahead and do 10 to 14 days of treatment in those cases. Now what complicating factors I'm talking about? Obstruction, instrumentation, impaired voiding, metabolic abnormalities, all of those kind of things, and immunocompromised patient in pregnancy. Those are the factors where you may want to go longer if they are not responding appropriately, or if they have delayed response. If they have prompt response, 2 days they were fine, 7 days is more than enough. 2-3 days they were fine, 7 days is more than enough. Now if you are treating a patient who is critically ill, hospitalized, then you have to start a parenteral therapy. Usually third generation cephalosporin is a good choice. You may have to do broader spectrum or add another agent if you are suspecting multi-drug resistant organisms. If you're suspecting ESBL because of previous culture results, then you may want to use carbapenem because that's the preferred choice. If you only time you need to add vancomycin if your gram stain is showing gram-positive cocci. And then once you have the culture back, you will de-escalate the antibiotics. Now, you can make the guidelines for your own facility. So this is an example of Nebraska Medicine guideline for Nebraska Medicine physician. And what they recommend in these kind of patients are to start with ceftriaxone if they are not suspecting multi-drug resistant organism. If they're suspecting multi-drug resistant organism, they say give a dose of gentamicin and then follow the culture result. If they're suspecting ESBL, then they start ertapenem. Now, talking about prevention of UTI in older adults. There have been a lot that have been tried. Cranberry juice, vaginal estrogens, physical activity, methenamine, long-term antibiotics. The only thing that has helped, that has been proven to be helpful in preventing recurrent UTI in postmenopausal women are use of vaginal estrogens. That's the only thing that has been helpful. Otherwise, the rest of the thing has a mixed results. Now, the long-term antibiotic prophylaxis has shown some benefit in a short run, but in a long run, you end up with problems of antimicrobial resistance, and when they get UTI, then they get it with more resistant organism. So that's why it's not recommended to use that. So for example, this study, you see that they have two groups. One, they were treating with trimethoprim sulfa long-term for a year, and the other one, they were treating with lactobacilli, the probiotic, for a year to prevent recurrent UTI. Trimethoprim sulfa group did better. They have 2.9 UTI episodes per year instead of 3.3 as in the lactobacilli group. So there was some improvement, some preventive effort. However, if you see the resistant pattern in the trimethoprim sulfa group versus the lactobacilli group, you can see a huge difference, and the difference started happening at 1 month. And not only trimethoprim sulfa became more resistant, amoxicillin became more resistant, Cipro became more resistant. So there is no point in putting the patient through that. Occasionally we may have to do that, but that shouldn't be our go-to preventive method. While we are talking about prevention, that's a little different when we are dealing with a younger patient, a younger premenopausal, non-pregnant woman. If you are seeing recurrent UTI in that patient population, so you have to figure out if that recurrence happens within a week or two of the last treatment, then it might be that they may have a resistant organism and you just may not have given the right antibiotics. So you may want to give broad spectrum antibiotic and this time take a UA in urine culture. If the recurrence happens after a month, then you can actually go back and just treat without you getting a UA urine culture with a different antibiotic than you used the last time. Especially if you used trimethoprim sulfa last time, change the antibiotic and treat. Now if they keep on getting recurrent UTI, then consider some behavioral counseling. So, reduction in frequency of intercourse, stopping use of spermicide, urinating soon after intercourse, or use some biological mediators like cranberry juice, although we know, for some people it works, but it has not been consistently shown to be effective. Antimicrobial prophylaxis is an option in this patient population as a last resort. Once you have tried all the other things, then you can use that. Now, if there are motivated women with previous culture confirmed cystitis who will comply with the treatment, then you can offer them to self-diagnose and treat by prescribing in advance, but have to reevaluate that periodically. Now, the other options are you use post-coital antibiotics, or continuous antibiotic for 6 months, and then reevaluate. Those options are on the table as a last resort. So finally, I would just like to highlight some strategies to consider for improving antibiotic prescribing practices in your setting. So if you are in outpatient setting, what you can do, or what has been shown to be effective, or what you can do is try to use the guidelines and try to educate the providers on those guidelines. You can make pocket cards, educational flyers, post it in the outpatient clinic. That has shown to be somewhat effective in reducing inappropriate use. Communication skills training may be very beneficial for the clinician so that they can talk to the patients who are demanding antibiotic and can explain to them in the right way. We have some communication skills talk on our website and a course on that. So if you are interested, send email to Dr. Chung and he will kind of guide you to that. So that's another thing you can try to do. You can have, if you have EHR, you can incorporate evidence-based guideline into the EHR order set, or you can have a culture follow-up program for your clinic. So if you send the culture, do a follow-up, call the patient, stop the antibiotic if their cultures are negative, or change it if they are resistant. So those kind of things you can do. In the hospital, as we mentioned, you can make a guideline and provide the providers with those guidelines so that they can have a standard way of treating, as we saw with the Nebraska Medicine one. Prospective audit and feedback, Dr. Srinivasan talked about that, has been very useful. Prior authorization for certain antibiotics, if they are being used a lot unreasonably, like fluoroquinolones, may help. Antibiotic timeout definitely help. Implementing IV to PO protocols can be helpful. And then if pharmacy can do some things like dose optimization and dose adjustments, those things can help improve antibiotic prescribing in your hospitals. In long-term care facilities, number one thing I will recommend, implement the SBAR tool. Establish and standing order sets for active monitoring for non-specific signs and symptoms. Now, you can combine the SBAR tool with the active monitoring protocol, and that's the best strategy you can do to improve antibiotic prescribing for UTI. You can do it for respiratory tract infection also in nursing home. We do have the SBAR for respiratory tract infection, for skin and soft tissue infection, and for UTI. So you can use that from our website. Facility-specific diagnosis and treatment guideline can be made, the same way as we made for the acute care hospitals. If the problems are the outside providers and not the inside providers writing for asymptomatic bacteriuria, then ask medical director to mandatorily review the antibiotic orders that are written outside from facility. Again, timeout can be helpful. Provider feedback. If there are some providers who are not sticking to the rule, then you may want to generate provider reports and just give them feedback on how the others are doing and how you are doing, and that can sometimes be helpful also. So these are different strategies. Whatever suits for your facility, you can try that. And with that, I will take questions. Thank you.